Hello, everyone, and welcome to the May edition of our free Q&A for home health. And I wanted to start by saying that we welcome and we thank everyone for the questions that they sent. Boy, it was a good group of questions this time. And I wanted to say I'm back. And I want to thank Adam and Scott, who are also on this call again, for covering for me for the last one. I missed you guys. And I need everyone here to know, and especially Cindy Kraft, who's also with us, that I am probably edgier than normal because I've had some experiences since the last time we all got together. So if you hear it in my voice, you'll understand. And I also wanted to mention about AI. A lot of folks are trying to put note takers and things like that through the as a member of the meeting, and we don't allow that currently, only because of the errors that can be made by AI and the assumptions that can be made. And we don't want any of the information that we give that's verbatim from the regulations to be misinterpreted or to have anything created off of it that may not be true. So if you see us denying your AI, that's why. Okay, Cindy, how are you doing today?
I'm doing good, Sherry. And as just an extension of what you just said, a reminder that these sessions are recorded. So a recording is made available to anyone who's attended as well as to anyone who missed the live session. So there really isn't a reason to use an AI as part of this. So I just wanted to remind folks of that, Sherry.
Oh, thank you so much, Cindy, because I forgot to mention that. But yes, you'll get the recording and you'll get the handouts for the contact information or any of the QR codes that we may have if you want to use them later. We encourage you to share this recording throughout your organization to friends, colleagues, whoever, because it's about getting the correct information out there. Home health is hard enough when we don't get great information. But when we give good information, we want y'all to spread it as much as we possibly can. So, Cindy, without further ado, let's get going.
I'm ready.
Okay, first question. I wanted to ask about the ongoing challenges in home health over the past few years, particularly the continued evolution of value-based purchasing. Part A, Cindy, it seems that agencies are facing increasing difficulty keeping up as DFS and point systems are adjusted so frequently, sometimes every few months. From your perspective, how are agencies successfully adapting to these constant changes and staying ahead?
Well, I want to preface this because, first of all, I want to acknowledge that the frustration around value-based purchasing, and it seems like, we had other programs before, Care Compare, that then became Star Ratings, that remained pretty stable for a while. The same metric stayed in for extended periods of time. And then occasionally they'd make a change or an adjustment, but it seems that with value-based purchasing, we barely get our feet under us, and then they change another metric. So we went from the assessment of function, including some items, then it went to, it's going to be this composite thing, then it became a discharge function score. Now we see the discharge function score is not just GGs, they've incorporated back some of the 1800s. So that frustration is real. I think, though, when you look at being successful, my answer, and I want to be very careful here, Sherry, might sound a little simplistic, and it's never meant to be condescending. I think very often when we don't like our performance in value-based purchasing, we look to what are all these other things we have to do? How do we fix it? And it goes back in part to the issue of OASIS accuracy, claims data accuracy, that the information that we're submitting to Medicare that ultimately gets used for these calculations is accurate. But I think sometimes we're missing that all of this is actually driven by the clinicians and the decisions they make for individual patients. And personally, I think that the changes in the metrics, which one is in there now, really raises the issue that this isn't intended to be hypervigilance only on certain items or certain metrics, only if they factor into value-based purchasing. Because particularly the GG items have been around for quite a while now, and in far too many organizations, they sat there because people felt they weren't really doing anything specific. So some chose to review, some chose to not. Some didn't really teach about that, thinking it's just kind of there. It wasn't affecting payment. It wasn't affecting anything else. And now it is. And now it's, oh my gosh, what are we going to do? What are we doing about eating? What are we doing about sit to stand? What are we doing about, okay. The reality is we're meant to be focused on all of those things that are measured by the OASIS, as well as the other things that go on with our patients that don't directly get measured in there. And I think what we've turned this into is such intense data monitoring that the actual decision maker is out of the loop. I see far too many clinicians that view that start of care, resumption of care, or discharge as a single point in time, that thing I have to do because it was assigned to me. And my primary goal is to get through it with as little correction as possible so that I can move on. And the moving on part, I think, is what's causing us aggravation when we look at things like value-based purchasing. Because yes, we need that start of care and resumption of care to be completely accurate, following all the directions, all the items, every time point, every time. And at the discharge, same deal. I need to know that those are being answered correctly. But what's going on in between those 2 points? Do our LPNs, PTAs, OTAs, home health aides, and social workers that can make up a big chunk of the episode of care aware of what's measured, how it's measured, what it means to move an 1800 from a 3 to a 2? How do we determine what is the underlying reason that this person needs this kind of help? And what are we going to intentionally do, mindful of being able to make that kind of meaningful change at the end? We also, with value-based purchasing as it stands today and the discharge function score, need to take a long, hard look in the mirror and stop obsessing about improvement. I know that's easier said than done. I know that Care, Compare, and STARS rely heavily on the public facing of improvement. Improve this, improve that, improve the other. But the discharge function score is an evolution in that says this does not live or die by improvement. That if the comprehensive assessment, if the OASIS and risk adjustment and all the rest of it say that the answers you picked for their functional ability were reasonable to assume that they could be better than that, then that is the projection and the expectation. If based on their assessment that, yes, they started out being completely safe and able to feed themselves, to roll, and to sit up, okay, they absolutely could do that at the start of care. And my projection now is I don't expect for them to decline in any of those areas by the time we're done. And stabilization of function is considered a positive patient outcome. I think some of our frustration is the relentless discussion of improvement that we've been living with for literal decades that can then create the temptation that, well, to do better, to perform better. Agencies have looked at, well, how are we answering that OASIS? And that's where at K&K we start to run into suddenly nobody can feed themselves. Suddenly nobody can roll without supervision. Suddenly everybody's dependent in toileting. And that's not supported by the documentation or the OASIS guidance. So when you talk about being successful, Sherry, I think this is a back to basics conversation about, yes, we collect this data. This is how it's measured. Do the individuals providing care, are they actively engaged in this? Because if it's nothing more than turn it in, and I'm glad, about that rule that nurses have to do the admit. So if they're ordered, they get stuck with it. That is never going to get me the performance from any outcome measure that we could have if the clinician was driving the discussion. I know that was a long answer, Sherry, but it's a complicated issue. And I already can see what part B is if you want to go ahead and read that and then share your thoughts. But I think sometimes we're looking top down.
I want to echo what you're saying. It's a very difficult situation that you find yourself in if you're really trying to game this and take advantage of some point system. And I'm just going to say this, home health is hard. And when you start trying to chase the adjustments that they're going to make on the data side, you're going to find yourself bogged down and overwhelmed very quickly. And you're also going to find that the thing that gets missed in this whole thing, while you're not paying attention to what clinicians are doing in the home, is that care that's being disseminated out in your agency's name. I think that sometimes we paralyze our clinicians somewhat, and we absolutely witnessed and we see pretty consistently some apathy when things start adjusting all over the place. So this takes some really strong leadership and really strong change management to get some of these changes across in a way that's going to be germane to the people that are out seeing the patients. And part B of this question is interesting. Are organizations finding success by expanding internal roles and hiring more specialized personnel? Are they relying on third-party QA and coding services, or beginning to integrate AI into their workflow? Go for it, Cindy.
I think if you look at that list, and I know that you're going to post that so folks can see what it says, but you're talking about expanding internal roles, hiring more specialized personnel, third-party QA, integrating AI. Again, those are all, I'm just going to call them extracurriculars. Those are all things that can very much support good clinical decision making. They don't replace or fix it. Because we're already seeing, and I'm going to pick one here, the AI and the technology coming in that's supposed to improve OASIS accuracy and make clinicians be faster. We're already seeing evidence in the charts we review that are clearly labeled with the disclaimer that AI was involved and the final decision is the clinician. But more errors in this than we saw before they started using AI. A narrative that is completely wrong and does not match the patient's gender, injury, age, anything, and yet is somehow in the same assessment. Items left blank that even basic EMR technology would call somebody out for just not answering a question and you couldn't move it to the next level. So my concern is not the technology, it's are clinicians engaged enough to read that before it goes to QA? Is this really about, I need more people hand-holding clinicians, or do I need to empower my clinicians with information and not the, somebody's going to fix this for me? When I hear clinicians kind of like, well, I do my best, but, QA's here to fix it for me. Or the reviewers there, they understand the money better, so they can massage the answer. Oh my gosh, we are coming so far off the rails with this. So I'm not saying we don't explore technology. I'm not saying we don't look at it and say, having a champion for VBP, someone who is not mad about it externally, but someone who can explain it to the clinician. And even the clinicians that don't touch OASIS, you need to understand what this is, that nobody's suggesting we're gaming. This is how we're measured. We need to be working on these kinds of things with our patient. And I'm sure you might be, but we got to get it more structured and intentional with respect to how these things are actually measured. The whole, we can't get our patients better. We have the sickest patients in the entire state. OASIS is terrible. I have no options. Those excuses just don't fly anymore. But I think that champion is really about, again, empowering clinicians, providing them with resources to assist. But fundamentally, if they're just going to rely on the AI and whoever you have QA the chart and whatever internal role is going to represent this at higher up meetings, I don't think the needle's going to move the way we want it to. Because just real quick, Sherry, my biggest one has been the issues around rehospitalization. We know that has been a big anxiety producer, not just from an outcome perspective, but in trying to get referrals, in working with larger systems. They want to know what our rehospitalization rate is. And when I talk to nurses and therapists about outcomes and what's going on and ask them to, okay, take a moment, think about publicly reported outcomes. What is the first thing that comes to your head? Extremely rare is it keeping people out of the hospital. And it's like, wait a minute, that's our number one job. How come every visit, regardless of discipline, does not lead with, what am I here to do today to keep this person out of the hospital?
Exactly.
Because if that mindset isn't there, we're out doing tasks, we're being nice, patients like us. I'm not saying we're doing anything bad, but what is the higher mission? Not how do I get my 6 points today? And oh my gosh, now I got to go to a meeting and it screwed all that up. That's the reality. I'm not taking that away, but I don't know if we've done the best job as an industry of explaining outcomes and VBP in a way that says this is how home care works and how are we doing the best possible job for our patient and making sure that we're documenting those metrics correctly.
Yeah.
People are trying to simplify. People are trying to simplify, and they're trying to simplify by creating answers that move the needle to improvement. And Cindy, you and I see it every day. Let's just call a spade a spade. I hate to say that, but I hate to say that calling a mouse, a cat, a dog, a dog. We have a lot of folks in our industry that are moving that needle artificially, and that is hurting all of us. And so when you start involving your agency members, your clinicians in those kinds of activities, that apathy, that disengagement, that I don't care, just put whatever you want, it grows exponentially. And just for edification, they know what's happening. And we've actually heard some of the clinicians and some of the frontline folks say things, they have to move it because that we know they have to move it to improve the payment. And that's something you never want to hear come out of one of your clinicians' mouth, but it's coming out of their mouths pretty regularly. So I would really caution you to pay attention to what the metrics say, pay attention to what's going on in your agency. And the amount that changes with the value-based purchasing, what's the total amount that they can deduct, Cindy, if you don't have the outcomes expected? 2%?
Well, it's in that 5% potentially, the swing being in VBP. But
you can chase that 5% as hard as you possibly can, and the other 95% could go right in the toilet.
Well, so, but Sherry, I know Scott has a thought, and I don't want to lose track of that, but I want to add to what you just said. I think it's fair to acknowledge that a flaw of the VBP is making it budget neutral. Because what you've set up is no matter if we all equally worked as hard on these outcomes, somebody will always be in the bottom half, no matter what we do. And then when you look at the data, the aggregate CMS data, and people are claiming that they improve dyspnea 99% of the time. Those are things that make you question the accuracy of the information being submitted, as well as, so I'm competing with somebody who claims that, I'm reporting honestly, I end up on the wrong end of that list, and now I get a payment reduction while you essentially reward questionable response. So I think those are the things it's fair to talk about, but the reality of the metric is the reality of the metric. And I think the clinician is not as engaged in understanding that this is not about gaming. We're not trying to, fudge the numbers. We just want to make sure everybody understands that the decisions you make on every visit either move us toward this outcome or they don't, because we have to have intentionality. So Scott, I want to make sure we don't lose track of your thought.
No, that was actually kind of a good segue. That the way you're looking at it, it's almost like it's multiple languages. You're looking at the VBP and the data-driven, that's one language. The actual job the clinician is doing in there is a different language. And then now we're throwing technology into it, and it's and you're trying to interact. I think basically understanding, you've brought this up where the clinician has a problem trying to understand how what they're doing day to day interacts with those other instances. So really just having somebody be like, hey, oh, it looks like we have to hit these metrics, but they really understanding what they're doing and how that they are already interacting with them by just doing what they're doing. The therapists come out there, they're seeing incremental change. They just need to learn how to document it and put it into a language that they understand. So yeah, that both you and Sherry basically hit that. So
all right, Sherry, that was 20 minutes on question one. What else?
Yeah, we got to roll. Okay, question number 2. If an MD identifies that it's bone mets, which is why the patient's fracture at the time, the patient's fall, and the patient's reporting having pain, then J1800 for fall is yes. Would you mark J1900B fall without major injury because the patient has pain? We would not identify it as M1900C major injury due to a new definition.
So kind of deciphering that question a little bit, we did see in the April Q&As discussion about the patient falls and fractures versus did something pathological underlying cause the fall to occur. So what we're seeing here is if it's identified that the fracture was due to bone mets, yes, it is reported as a fall, but the issue is whether or not there's an injury. And so the question literally asked, would you choose fall without major injury because the patient has pain? Looking at the official guidance, it tells us that we are to select no injury when there's no evidence of any injury noted on the assessment, no complaints of pain or injury by the patient, no change in the patient's behavior is noted after the fall. Injury except major includes but is not limited to skin tears, abrasions, lacerations, superficial bruises, hematomas, and sprains, or any fall-related injury that causes the patient to complain of pain. So based on that description, the patient has a complaint of pain. So yes, it would be correct to classify it as a fall with an injury except major.
Okay. And that goes against what we think clinically sometimes, because, I'm sitting here as I'm reading that question thinking, well, if they don't fall, do they fracture? Did the fracture happen before the fall? There's a lot of other mitigating factors in that, other than that. But thank you for that guidance, because that makes it pretty clear.
Mm-hmm.
Okay, you ready for number 3?
Yep.
Okay, does M2401 intervention synopsis have any impact on the agency's outcome? Under survey, the auditor did not understand why we had a pain order for a patient without complaints of pain. In the CMS OASIS Q&A's Category 4 OASIS dataset, forms and items, there is a guidance that states as long as we have an order and provided education to the patients, then 2401 can be marked yes. But the surveyor did not agree and felt it was unnecessary. Please share your thoughts.
Well, first of all, 2401 is not an outcome directive. It is very much process measure. It's asking a whole bunch of, did you do this? Yes, no, or NA, because I didn't have to. So anytime we're getting directly asked OASIS questions that are yes or no, they are typically not an outcome discussion, because there is no baseline. Like if you take a functional question like 1830, you score it one way at the start, you do the discharge, it's a different answer. You can see what the outcome has been for the patient. Anything that's yes, no, or only shows up once, because we know 2401 is on a discharge. We used to have an equivalent at the beginning of care. And honestly, Adam and I had this conversation the other day. I wish it was still there. I think it went better when we were reminded of these various things when care started and then circled back to them at the end. Taking it off from the beginning, I think, has made the discharge one a little clunkier. But those are process measure questions. Now, specific to the issue of pain, what we want to be careful of is the surveyor, based on what we're reading in the question, didn't say this was a problem or didn't cite it, just felt that if the patient really has no pain, then doing this is unnecessary. And I would think that I lean to agree with the surveyor. Because when we look at the response options related to that pain question, first of all, it says that in order to pick yes, we have to have orders and demonstrate what we've done to both monitor and mitigate pain. And it clearly says you have to do both. So if my order is simply just to monitor it and I'm not doing anything to mitigate it, then technically I can't say yes anyway. It has to cover both parts. But NA is there indicating that every pain assessment over the course of care did not indicate that this patient had pain. So I think the idea of, well, it's at the start of care, they're not complaining of pain, but they could have pain over the course of this episode. So I'm just going to put in a monitor and mitigate thing on everybody as a precaution. Is that harmful? I would say no. But it does beg the question that if they didn't have pain at the beginning and we checked on their pain level throughout the course of care and they never did have pain, then, okay, you could argue I monitored it, but what did I impart to mitigate it if they never had it? And so I think to consider an alternative is it's okay to say this patient doesn't have pain and I'm not putting this in the plan to monitor and mitigate. And over the course of care, I am going to ask the patient if they have pain. Boy, everybody's going to ask them if they have pain. And if through 2-3 weeks in, okay, wait a minute, now they are having pain. Yes, I do have now something specific to address monitoring and mitigating. And I add that to my plan of care. Then when we get to the discharge, it has occurred anytime over the course of care. So if I added it later because the issue did present itself, then I can see why, okay, this makes sense. But I kind of lean with the surveyor, and I'd be curious, Sherry, if other folks want to chime in on the chat, that if they really didn't have it at the start and never once complained of pain over the whole episode, again, I could see that monitoring. I'm not sure how that's mitigating, and I'm not sure why you'd want to do that. NA is perfectly acceptable to say that I didn't need to do this. And that's why they have the NA column throughout 2401, because there's going to be situations where I didn't need to do that because it wasn't an issue for the patient. And we know there's a huge difference when we mark NA versus no, because no is completely different. They're not interchangeable. No is this issue existed and I did not do one or more of the things required. Now, sometimes we have to honestly report no at discharge as well. The patient may have opted to discharge themselves sooner. Something may have interrupted this and caused these things to be appropriate and ordered, but I didn't execute because there's a very valid reason I did not. But we don't want folks interchanging accidentally no and NA because they mean very different things.
And also, I would encourage you, if you do have a disagreement with a surveyor, it is okay. In fact, I highly encourage that you ask for the reference and the regulation that they're referring to. Because if we all know one thing, and a lot of people on here are probably nodding their head, the surveyors often get things misinterpreted wrong. And it's our responsibility to ask for that guidance that they're receiving that from, and even have a comment on it when if we have a discrepancy on our survey that we mentioned. If they put it on the survey and we have to answer it, that we mentioned that we had a disagreement with the surveyor in that situation. So I would encourage you to listen to what the surveyor has to say, but then always ask for that reference that they're reading from. And I want to encourage everybody, I'm going to switch slides here, and we have a club OASIS. Our Q&As often lean heavy OASIS because this is a long document. It has a lot of different interpretations, a lot of different scenarios that we have to deal with. And our Club OASIS is a place where you can get some of these answers faster. And you can access colleagues and you can talk it through in a more timely fashion than every couple months when we do our Q&A. So if you haven't joined yet, you can join and you get the first quarter meetup that we had, and you can even access the assessment for your staff if you want to join it. We do have discounts for larger groups, but this is something that we do every quarter starting in May. We just had our first one May 5th? I think it was on Cinco de Mayo. How'd you do that, Cindy? Anyway, we had that and it was very successful, but it's basically you're purchasing your Q&A meetup and your Q&A walkthrough with Cindy 4 times a year with this very low price situation. And we have a discount still going for nurses until the 31st of May as our extension of Happy Nurses Week, because we think you deserve more than just 1 week. Okay, Cindy, we ready? Okay, number 4, April 2026 Q&A. For the GG0170, if a patient does walk 10, 15, or 150 feet, but is unsafe while doing it, despite any type of assistance, how should the GG0170 walking activities be coded? Should they be coded as O1 dependent or coded with an activity not attempted code?
So I will confess, Sherry, that I added that to your list.
Okay.
Because this keeps coming up in a variety of different ways. So I thought the best way to deal with it here was to use the actual Q&A that dropped last month. So you've posted the question in there. Now, if you want to go ahead and post the answer, I think that this is an interesting issue because when we think about activity non-attempted codes, and that ties us back to the value-based purchasing conversation, there tends to be now a big shift away from them, because we know that the math involved of using an activity non-attempted code is complex, and that it gives the appearance that we should avoid them. I'm hesitant. I don't like the word avoid them. I think the word is minimize them. Having looked at some of the raw data prior to getting into VBP, there was way more activity non-attempted codes being used in home health than I would have expected, especially for questions that have direct overlap with 1800s. I'm not quite sure how we answered 1800 and then turned around and put a bunch of activity not attempteds in the GGs. But what's done is done. And so I do agree that we need to be careful in how we use them. But there is a specific ANA issue related to the ambulatory questions. Because when you look at things like the bathing, the dressing, it does clearly state in the manual about, interview, demonstration, discussion with the patient, talking to others. I mean, looking at record. I mean, it gives you a lot of ways to be able to infer, okay, I'm not necessarily going to make you take a shower, but based on what I'm seeing and understanding, this is the level I'd put you at. There's a little bit more leeway there. On the ambulatory questions, when you're talking about 10, 50 feet, 2 turns, or 150 feet, they are consistent and reiterated again in their answer to this is you have to complete the distance safely, either on your own or with the assistance of others. If the patient cannot get to 10 feet, can't do 50 feet with 2 turns, cannot get to 150 feet, even with assistance, it is a non-attempted code. Because the question was posed, well, if they can't do it despite any type of assistance, does that make them dependent? Okay, dependent as defined in GG could mean 2 people. And if it took 2 people, and with 2 people, the individual was able to safely complete 50 feet in 2 turns, then yes, you can score them as dependent because it tells us if it's 2 people, that's the only one you can use. But we got to be careful of this dependent 2-man drag idea. I've heard some of this recently in other Q&A sessions, Sherry, about, what if I drag them the last 5 feet? Okay, hold up. We're not dragging people, okay? Ambulation, Sherry, the reason you're laughing is you and I are both therapists, and we know full well what dependent ambulation is. That's a 2-man drag. And that's not functional, and that's definitely wouldn't be going 50 feet, turn 50 feet. I mean, we wouldn't do it. If you completely cannot do it, you cannot do it. And CMS echoed that in their response to this by saying, when coding activities in section GG, clinicians should code based on the type and amount of assistance required to complete the activity, allowing the patient to perform the activity as independently as possible as long as they are safe. If the patient does not participate in ambulation for the entire stated distance for a specific GG 170 walking activity, or if the assessing clinician determines a walking activity is unsafe, even with the assistance of 1 or more helpers, then consider the walking activity to not have been completed and use the appropriate activity not attempted code. Mm-hmm. So there's not a lot of leeway on these in terms of, well, I got them to 30 feet and I think they could do 20. When it comes to those 3 in particular, they repeated what they always do. Is it safe? How much help? Blah, blah, blah for all the GGs. But specific to this, they got to make the distance. They got to do 50 feet in 2 turns. And if they can't, even with help, or it's ragingly unsafe even with help, then it is an activity not attempted code. And we have to make sure that those efforts around VBP and OASIS and data collection, that we have not gone too far in the don't use them. I mean, we've seen recent audits where QA's putting directly into the EMR their feedback to the clinician, we do not use not attempted codes here. That could be a huge risk, putting that right into the EMR, because there are clearly situations, and CMS is reinforcing it here with question and answer 5 from April, that this is exactly how you're supposed to handle those ambulatory questions. And we want to make sure that our clinicians, regardless of discipline, are applying that consistently.
And consistently that still meets with your clinical standards. I mean, if I'm auditing a chart, and Cindy and I both being therapists, if we saw max assist of 2 for that particular one, we know what that looks like. So there's a foot dragging somewhere with max assist of 1 or max assist of 2. And also we want to know who's that second person.
Correct.
and it can be very dangerous to try those kinds of things. And there's so many pre-gate activities that you can do and mobility activities you can do outside of that distance of walking. Sometimes that's not a realistic goal. In the case of some of the folks that we're seeing in the home now. And so making it clinically relevant and clinically appropriate is part of that whole skilled, reasonable, and necessary when you're doing your documentation beyond the OASIS. So
Well, and
keep an
I
eye on
think
that.
with that, Sherry, where it gets confusing is when you see that, let's say that the 150 feet is scored a 3. And then you look at therapy evaluations and that person can't go more than 25 feet. Then it's
Right.
like, wait a minute. So how did you get to 150 feet on the admission, but now they really can't get that far? So I think that's important when we look at demonstrating activities. If we're held to literal distance, then those 3 absolutely have to be demonstrated. And we can't infer it. And it becomes very clear if it's being inferred when we see wildly different. And I'm not saying use the therapy eval, go back and tell the nurse to change it, because that's not actual collaboration. But it is going to warrant the therapist and the nurse should probably discuss this about what the actual answer is to GG 170, because if they can't go more than 25 feet, how on earth did you get to they did 150?
Or if they have a huge house, how did you get to, they got to the bathroom and back and not get past the 50 feet if the house is a 4,000 square foot house?
Correct.
Sometimes you have to take that into consideration as well. And Cindy, I'm kind of chuckling underneath under my breath right now, because I know that every time you say the term 150 feet, you get a twitch.
Ugh. Yeah, there's any other number. I mean, if we had another hour for this conversation, Sherry, don't wind me up. Because we know that 150 feet has been stuck to the whole, like there's a perimeter line around the house that if you go more than 150 feet, you're no longer homebound. And we've been fighting that battle for decades to have the GG pick that number. I'm like, any other number. You could have picked 100, you could have picked 200. Why did you take 150 feet? Because it just makes this work.
And the quality and safety of that gate distance is way more important than the actual distance. And so I think we need to remind our therapists and our clinicians, all the clinicians, that walking horribly for 150 feet is not as good as walking 10 feet well. And I say that with a good gait pattern, with good safety, with good foot clearance, all those clinical aspects to it. And so I just wanted to poke the bear a little bit, Cindy, because I know 150 feet is a trigger. Come on, I have to have some fun.
Yes. Did you have something to add, Adam?
Yes, I had a very short tangent because you kind of briefly alluded to this. I would strongly encourage clinicians to document in the narrative note or wherever else you do it, when you select one on a GG item because it requires 2 people, that you document that. Because it's fairly common. We see, a surveyor might see, oh, they can do these other items with certain amounts of assistance. How's this one suddenly dependent? So document.
Amen. Amen, Adam. Okay, number 5, we ready? Moving on?
Yep.
Okay, this is from question number 1 of the April Q&A. In the draft OASIS E2 guidance manual, chapter 1, convention number 9 stated, an agency software may not answer or generate the OASIS response for the assessing clinician. Elaborate.
Oh, yes. We've had a conversation about that here. We've had it on Club OASIS. I think we've had multiples. What they reiterated in the answer was that the final version of the E2 guidance manual, they reworded it. An agency software may not answer or generate a final code for the OASIS items. So we can see where, okay, now you've given some leeway to technology or review process that the final stay still remains with the clinician. But that's not where they stopped. They added another sentence. Following agency policies, the assessing clinician is responsible for considering available information and ensuring the appropriate OASIS item responses were selected within the appropriate time frame and consistent with data collection guidance. What jumped off at me, Sherry, about that was following agency policies. So we went from the original version of that kind of went, oh my gosh, what are we going to do? It basically said you couldn't help them with answers to, okay, that got fixed, but wait, there's more. Because it's not just saying general agency policies about, this is saying the assessing clinician is responsible, and it lists it out. Appropriate OASIS items within the appropriate time frame, consistent with data collection guidance. I think this means we need to revisit policies. Do we have policies regarding this? I mean, I know that it's long been known in the manual that, you know, the clinician has the final say. And as I mentioned earlier, we've seen AI slap that on the documentation already with, you know, AI was used to do this, but clinician has the final say. But have we ever really had agency policy about this and what the expectations are in terms of appropriate timeframes and consistent with data collection guidance? I take that a step further, Sherry. You said you were a little ornery. I'm gonna be a little ornery. I would argue that following the guidance in the appropriate time frame should be a policy for anybody who touches it.
Amen.
Not just the clinician, but anybody reviewing it needs to be doing the same thing, because that is really the only safe space that we can exist in. Is what does the guidance say? And if it doesn't say what you're trying to say, you can use a Q&A process to try to clarify that. But I think we've seen more issues around coloring outside the lines related to this, that I just wanted to highlight that piece because it softened the original concern, but I think it added something that we're going to have to consider about what is agency policy, and have we ever really put anything pen to paper about the accountability to timeframes, data collection guidance, and ensuring that the appropriate. It made me think, Sherry, about when you've mentioned to me is it from a billing perspective, what you have to check up. You know what I'm remembering? I just can't think of the right words at the moment.
Oh, the checklist for billing to make sure that everything's in compliance before you drop your first bill. Yeah, you have
Yes.
to make sure that all the necessary pieces are there, and not just there, but that they make sense to be there or not to be there. And some of these things you have to remember, and we all have to remember as providers, that you're held to the strongest of three things: either the federal law, the state law, or your internal policies. So following the federal and the state is super important to guide you in your policies and procedures, because you can hamstring yourself by writing more strict policies and procedures. This one is pretty clear as far as how they want it to be written, and just reiterating what we all know, that the clinician has the final say. And that's where it's important for leadership to keep clinicians engaged in this process, so that you get their clinical opinion and their clinical knowledge, because when it comes down to it, that's the important stuff that occurs between the patient. And I'm not saying that the QA isn't important, but it's really important that your clinicians are engaged in the answers that they're providing.
And that I think that it would be a good opportunity to revisit that idea of following the guidance as
Yes.
a reminder to the clinician, because I know there's at least one person listening that's going, yeah, I know they have the final say, and they argue with me. And even when I, explain that 2 should be a 3, they get indignant and refuse to change it. That is where I think sometimes some policy discussion around that accountability to the guidance could be an interesting conversation, that it's not just you have the final say, no matter what it comes from,
Mhm.
but it is in the context of the guidance. So there's times where your answer does need to change because the assessment supports this other answer. To just say, I'm not gonna, is not really following the instructions. So
And
Yeah.
on some things, Cindy, it's a no-brainer. On some things, we would say, well, you can't work with us if you're not going to take the blood pressure. You know what I
Mhm.
mean? If you're
Mhm.
not going to take the blood sugar, if you're not going to do, there's some things that
Right.
clinicians will draw a line in the sand that's unreasonable, and it's really unreasonable for them to disengage and become apathetic with these answers. But again, I as a former agency owner, if it came down to a blood feud with me and a clinician over an answer, their answer goes. And
Mhm.
that's something that Medicare has spoken pretty firmly on. And so I want everyone to remember, yes, we're trying to make as quote unquote much money as we can, but I say as much money as you're supposed to make for that case. And having folks that are flexible enough to learn and have an open mind is super important as well. All right, we ready?
No, I was gonna input one thing. I think whenever an agency is wanting to implement something like AI or something that's going to help generate or help provide insight or recommendation or anything like that, and we're starting to look at the policies, it might be good to revisit how the EMR interacts too. Because if you're looking for some of that accountability on whether or not the clinician is taking these as suggestions or just saying yes. Some EMRs have built-in features where if any type of change or anything, the clinician has to go line by line and accept those or decline them. Where so it might be interesting to try and make sure that that could be written into your policy that, oh, they are doing this if your EMR doesn't do it for you. That I was able to see which ones were generated by the clinician and which ones were generated by the software. So
And I, Scott, I'm going to kind of echo on that. You have to have people that are willing to be intellectually involved in this process. And so my concept is when I played college softball, if we didn't make a certain grade, if we didn't do as well in class as we were supposed to, we had mandatory study hall. And mandatory study hall was at a time that nobody wanted to be there. It was usually around 7 o'clock at night, and you had to be there for an hour to 2 hours, depending on what was going on. And you had to check in, and that was part of your responsibility as a scholarship athlete. Maybe consider instituting an OASIS study hall for those that are just really struggling to get it. I know that home health clinicians, one of their least favorite things to do is come into the office. Well, you can get out of that if you're willing to be a sponge and take in this information and disseminate it appropriately. But if not, think about a study hall where you have 2 or 3 of your clinicians that maybe are struggling, or maybe just have some, or maybe they're new to your process. Have them come in and spend an hour in the afternoon in concentrated time while they're doing the document, so that you can make sure that they get it. They're doing that from the right perspective. But that's a tough thing to do. But it's something that maybe be able to enforce what it is you're saying and how important it is. Okay, number 6. On a non-visit DC OASIS, we have guidance, for example, 1740, that this item is intended to be a patient self-report item. No other sources should be used to identify the response. However, there is no option to mark not assessed. None of the answer options are valid for a non-visit discharge. How should this be handled? This is another poke in the bear, Cindy. Go.
Yeah, folks that have been with us for a while on these have heard my rant before, so I will try to keep it brief. My initial disclaimer is we all need to keep in mind that the non-visit discharge is meant to be a rare exception, that this is not a routine occurrence. And in some cases, as we've worked with agencies, we find a much higher than expected number of these non-visit discharges. So I think it's important. We're going to deal with the technical of the question, but I think it's an important reminder to keep track of how often these non-visit discharges are happening. I would say to the individual clinician as well as to the day of the week. I don't say that in any mean way, been there, done that on the clinician side, but I noticed as a personal example that when we would get a bunch of PT evals in on a Thursday and I would go around and assign them out on Friday, that interestingly enough, that was the largest percentage of them that all wanted to wait till next week. And I began to question, did they all really wanna, or did they, oh, I'm kind of tired, I just got home, and we saw an opportunity to lighten the load. I get it, survival mode, especially when we're short-staffed, but the same thing I think can happen with these non-visit discharges, that scripting of it is an important visit. I think sometimes the patient doesn't quite understand. I mean, they're doing better in many cases. They're glad to be done with, they liked us, but they're glad to be done with this and be able to move on. And so I think they think they're being nice about, you don't really need to make this visit. I'm doing okay, honey. You don't need to. But I think we need to remember that that assessment is a significant part of outcome measures and process measures, and we want to do it in the presence of the patient. Now, if they're absolutely refusing or their circumstances beyond our control, I get it. But I just want folks to keep an eye on that, because I think when staffing gets tight, when things are going on, there just seems to be an uptick in this. And I think there's been such an uptick in questions related to this that if you look at the final version of the OASIS E2 manual, if you go through that PDF near the bottom, they talk about the differences between E1 and E2. So that's where the Convention 9 about, final answers and all of that was. But they tend to put in red the language that they've added or modified in the latest version of the manual compared to the previous. And there was a lot of red around the non-visit discharge. I think they're still trying to clarify this is not the preferred method. But what do you do in those situations? So I went in there and pulled red language to read verbatim in terms of addressing the question that was submitted to us. So items where a dash is not a valid response. If assessment of an item was not completed prior to the unplanned discharge and there is no information available from the last 5 days the patient received visits, code the item using any available documentation or information. For patient interview items where the dash is not a valid response, if the patient is unable to respond due to an unplanned discharge, it is allowable to code X or code 8, patient unable to respond, depending on the item. Review the guidance manual and Q&As for item-specific guidance. So in the absence of a dash, if we have those interview items that have the unable to respond, it is directing us to use those, because technically speaking, they are unable to respond. We didn't get to interview them because we didn't make a visit. The other one of, yes, we know that in a situation of an unplanned discharge, we have to go back to the visit of the last discipline that could do an OASIS. And then we can look at the last 5 days in which they received visits. So the last physical visit and then the 5 calendar days prior, did anybody else see them that we could talk to? That they are saying when you have absolutely no other choice, you can look at documentation information and do the best you can. You can see why, Sherry, in an outcomes environment, in a VBP environment, these non-visit discharges don't help us.
No.
We can't do the interview.
Interestingly enough, that they use the word unplanned in those
Yes,
answers.
very much
Because
so.
Unplanned means you didn't give them the notice of non-coverage. You didn't give them any of the other things. Something occurred. So CMS is assuming that there's some rare thing that occurs that you can't
Correct.
plan the discharge, like the patient moves to their daughter's house 3 states away. That's an example.
Right.
But the non-visit is something that we've created as an industry.
And I've even heard people, Sherry, want to create a visit type for that or a form for that. And I'm like, how often is it happening that you need that? Because I think it was one thing you could argue that it affected Care Compare potentially or our star ratings, but you look at the financial implications with VBP and that discharge function score. I mean, because you have to go back, I mean, it's clumsy and it's risky. It's risky, especially with interview questions. And now I'm putting in an answer that they're unable to respond. And we know how unable to respond is actually defined in the tool. But now they're saying, well, in this circumstance, you can use that because technically you couldn't ask them. It's like, okay, we're always just trying to patch this up. So again, there's plenty to look at. I would highly recommend you look at that final version. It's all in red, all the stuff that they updated, but there was a big chunk about the non-visit discharge. But you're right, Sherry. Those responses very much read like in the rare occurrence of.
Yes,
They're not encouraging this. And I think in outcomes driven, we shouldn't be facilitating them either. Unless we have absolutely no choice.
I'm going to steal Scott's statement on our text chain. It says, treat it as a home health graduation party. Explain to the patient how important it is and leave them with a great feeling of your agency before you leave as a marketing tool. Hey, if you ever need care again, if you ever need assistance again, call us. We would love to come out and take care of you again. Those kinds of things can't be overlooked. And I think tying things up in a nice little bow is always a better way to go than the non-visit. So avoid those non-visits. Unplans, we can't do anything about. Non-visit ones, we can do something about. And so making sure that we stay diligent on that. I switched the slide, Cindy, because I think it would be remiss of us if we don't mention what's happening. We are under a crush of audits in our industry, and it's all tied to the moratorium. It's all tied to the no new hospice and home health agencies. The RAC auditors are getting special instructions about how to do their audits, but also the MACs have gotten re-instructed on the TPEs because they're going to be using those even more. Do not look at Los Angeles and think, oh, it's just Los Angeles. It's everywhere. We're getting calls from all over the country about ADRs that are very specific. And so if you need to have a pre-audit done to start fixing anything in your documentation or in your compliance process prior to receiving an audit that could potentially cost you a ton of money, please let us know. If you receive an audit or an ADR request, call us first. So important. Because it can take a lot of your manpower and a lot of your FTEs to handle a big audit. So make sure that you get some expert guidance, some expert assistance that's going to tell you the truth, because there's going to be claims. Cindy, we have some that are actually clients of ours. There's going to be claims that are not going to be worth fighting for some reason. And those, you need to hear that, because you can waste a lot of money chasing a claim down. You can actually waste more money chasing a claim than the claim is actually worth. And so acknowledging that that's a mistake and acknowledging what you want to work on and what you want to spend your time on is super important in these situations. But if you're not feeling this pinch, it's coming. I hate to be that Chicken Little, but Cindy, I didn't know if you had anything to say about that before we go to the last couple questions.
Well, I think that, you know, the moratorium caught a lot of attention in terms of, you know, they're saying it's 6 months, but they could extend it if they want to. But I think buried in a lot of that press release around the moratorium is the intended increased scrutiny.
Mhm.
So there was one thing to talk about crush. Now we've closed the door to keep additional robbers out.
That's exactly it.
Now we got to look in and figure out how to get the problem people out. And anybody who's been paying attention to the number of agencies that can't bill now, yeah, you can argue a lot of it is in California, but hospice and home health, this is no joke. And entities and CMS contractors are showing up at agencies now saying it's a complaint survey, but it's not really. Now they're arguing it's a different kind of survey. We got to just make sure we're ready. And our house is in order and we haven't let things kind of slide, because my fear is whenever they take on this kind of full court press, they often capture people in that net that are not doing anything on purpose. They're not trying to do something wrong, but they lost track of some of the rules or maybe got some advice they shouldn't have taken. And now they end up, look at these people doing these bad things. So we just got to make sure everything is in order. It doesn't mean they won't pick us, but we want to go into it prepared and not just assume that if I haven't had an audit in 5 years, they're definitely not going to come look at me.
And be wary of the consultant that's going to come in and look at the ADRs as an individual action. They should be helping, your consultant should be helping you fix the underlying root problems as they're finding these things. And if they're not, they're trying to extend out the amount of time that you're paying them. So be very careful in your choices, that you're going to get some advice on how to fix it going forward, so that if you receive a second round of ADRs, you're going to be in much better shape than you were with the first one. So that's something that those providers exist. You just have to find them. Obviously, K&K, that's our mantra, is educate, try to put ourselves out of a job by education and making our agencies better. But that's what you should be looking for in your consulting agencies, that they're giving you tangible things you can do, tangible action items and action activities that you can do to make sure that those things don't continue to hurt you over time. Cindy, I don't know if you had anything else before we go to our last question.
Nope.
Okay, last question. What should agencies do when they have a catheter patient under Medicare that has non-healing chronic wounds? Do you continue to provide the wound care, or do you only provide the catheter care, since Medicare doesn't cover non-healing wound care?
I'm interested on your thoughts on this one as well, Sherry. I looked at it and I'm like, I am not familiar, and if a listener knows something I do not, I've never heard Medicare doesn't cover non-healing wound care.
Yeah,
So
that's,
I'm not sure how you could just do the catheter and ignore the wound on a Medicare patient.
I don't think that you can. And I think that what agencies often do with these catheters or these B12 patients that are just the same thing every month, they tend to get very lackadaisical in their evaluation at each research period. We need to be looking those patients with new eyes every 60 days. And if there's any additional services that they require, okay, non-healing wound care, all I'm saying is skin is an organ. And if you have something that's going on in your skin, it needs to be addressed by a appropriate clinician. So that is absolutely covered in conjunction with the catheter care and should be billed under Medicare, just like you would, or Medicare Advantage, or whoever the payer source is, because it is part of what is happening with that patient. We're a Part A provider. We provide comprehensive care. So that is not something that's separated out from a catheter.
Okay. That's what I thought, but I was like, I'm not going to charge in, and if somebody knows something different from that, I'd be curious, because that just didn't make sense to me at all, that you could somehow ignore that as, because
Yeah.
it would end up in your assessment somewhere that it was there.
Well, we could throw that into a maintenance scenario very quickly, because that's something that you need to be looking for each and every time, what skills and services you can provide that patient with the ultimate goal of keeping them at home and out of the hospital. And the thing with non-healing
Right.
chronic wounds is they can turn on a dime. They can turn very
Yep.
quickly without the proper care. So that is definitely included. Put up the last slide. I want to say happy Memorial Day to everyone. And I know some of y'all just got a twinge because now you have to schedule for Memorial Day, or you already have, but still it's always an interesting time in home health. And I wanted to make sure that everybody knew that our next session is going to be July 23rd. It's the fourth Thursday from 1 to 2 p.m. And please register and get your questions in, because this is so good because it's your questions and it's your scenarios. Well, Cindy admitted she put one question in this time, but
I put both ones from the Q&A, because those are two things that keep coming up that I thought was easier to condense it and go back with an official response than a bunch of different questions related to the same thing.
if you are interested in joining Club Oasis and you want to get your nurse discount, email me at st@knkhelp.com. Or if you need more than, we have special pricing for 2 to 9, 10 to 20, or 10 to 30, I think it is, and above 30 pricing for the Club Oasis. And it's really an actionable place that you can get answers and not just commiserate, but get colleagues that are all over the country, and that have, some of them have the same questions, and you can get answers very quickly. So Cindy, did you have any closing thoughts?
Oh, no, sometimes we call Club Oasis a support group.
It can be.
It's because some of this stuff, especially when some of the Q&As come out and you go, what? Who asked that and why? But like I said, it's really just another attempt to get information out there. We know folks overwhelmingly want to do the right thing for their patients, and there's so many different things we have to keep track of that if K&K can help in any way, we are more than happy to do so.
And thank you so much for participating and coming on to the Q&A, and we'll see you guys in a couple of months. In the meantime, please be safe.